Dr. Patrick Go is an assistant professor in the psychology department at the University of Hawaii at Manoa. His research focuses on improving ways to identify children at risk for ADHD early in life and provide therapy that accounts for their unique culture and contextual situations. He's particularly interested in focusing this work on Asian American, Native Hawaiians, and Pacific Islander populations because these communities are commonly overlooked in research studies. Dr. Go is also experienced in implementing evidence-based therapy to manage ADHD and related issues in the home, classrooms, and community. Today, he will be providing some up-to-date information and practical strategies on how to manage and help children with ADHD. Please welcome our speaker, Dr. Patrick Go.
Okay, great. Thank you for the introduction. And thank you also everyone for joining me, taking time out of your Sunday to learn more about ADHD. My name is Patrick, and I'm going to be presenting on how the child aspect of the disorder in terms of its assessment, its treatment, and kind of current research endeavors that the field is going through right now. And so I'll just go ahead and jump in here. Like I said just now, the objectives of today are to define ADHD, what the disorder is in childhood and adolescence, to grow familiar with evidence-based assessment and management of ADHD during childhood and adolescence. And then at the end, I also am going to go over some new research on ADHD that I think will be very relevant to kind of the work that I hope, that I imagine a lot of you are either doing or working towards doing in the future. And then so before we jump in, I know I did already, but like I said, my name is Dr. Patrick Go. Y'all call me Patrick. I'm an assistant professor at the University of Hawaii at Manoa. I'm originally from Los Angeles, and then I got my doctoral degree at the University of Kentucky, spent a year in Chicago, and now have lived in Hawaii for 2 years almost. My research in particular is focused on understanding how ADHD or what ADHD looks like and how it's treated in different populations, with a particular focus on Asian American, Native Hawaiian, and Pacific Islander communities. Those have largely been ignored in the research up until now. And so I'm really trying to focus on if the way that we viewed or these communities view the disorder, as well as how they view treatment of it, differs, and whether that's something we should take into account. And so jumping in, I really want to start, or I tend to start these presentations just to make sure that we're all on the same page with defining what ADHD is, and perhaps more importantly, what it's not. Because as I'm sure many in here know, ADHD is really defined by these two groups of symptoms. And so there are the inattentive symptoms, which are things like difficulties concentrating, forgetfulness, troubled with being organized. And then there are the hyperactive impulsive symptoms. That's going to be the restlessness, difficulties sitting in one seat and staying there, interrupting others when they're talking, things like that. And currently, the way that DSM-5 groups ADHD diagnosis is into these three distinct, so to speak, presentations. Y'all might have heard of subtypes. That was used in the past, but in general, the DSM has moved past the ADHD subtypes and into presentations. It's been found that the subtypes are not really stable. And so that just was an inaccurate way of describing people who have the disorder. For the presentations, they're really defined by how many symptoms are exhibited by a child. And so if there are greater than 6 symptoms, that child is viewed as meeting criteria for the predominantly inattentive presentation. And then if they meet criteria for 6 or more of the hyperactive impulsive symptoms, they then fall into the predominantly hyperactive impulsive presentation. If they meet both of the criteria I just talked about, then they meet criteria for this third presentation, which is the combined presentation. And then I do always mention here, I know it's not what I'm going to be focusing on today, but the DSM criteria was also modified so that in children, it's 6 or more symptoms to meet criteria. In adults, it's going to be 5 or more of the symptoms. The reason for that is that it was found that the ADHD symptoms, which were oriented originally at children or historically at children, don't necessarily capture the disorder during adulthood as well as in childhood, so to speak. And so the symptom criteria was modified to be a little bit more accessible in adulthood. Along with the symptom criteria, the symptoms have to have been there for 6 months preceding the assessment, at least. They must be present before age 12. There's a lot of talk right now, both in the research world as well as kind of the layperson, shall I say, pop culture world about adult ADHD. And this is really a really important consideration given all of that going on, is that in its current form, the symptoms of ADHD must have been present before age 12 in order for a diagnosis to be given at a gold standard level of clinical care, so to speak. A lot of times we'll be going back to report cards, to teachers, to things like that. And certainly there are pros and cons to that approach. And then the last criteria for a DSM diagnosis is impairment in 2 or more settings. A lot of times for children, this will be school and home settings. And certainly once you get into adulthood, then work comes into play as well. So the disorder can be diagnosed starting at age 4, according to the American Academy of Pediatrics guidelines. It's been found, these large-scale studies have found about a 5 to 7% prevalence rate of the disorder, with it being about 3 times more prevalent in boys than girls. Research has also suggested that ADHD is slightly more prevalent in those identifying as Black, and then also those who identify as coming from low SES backgrounds. There are slightly higher, but still meaningful differences in the disorder prevalence rates in those communities. And then I do always make a point here to say as well that some adults who had ADHD as children sort of fall out of criteria. And so it has been found that in people who have the disorder as children, several of them will not meet criteria for a diagnosis in adulthood. But that being said, it has been found that the symptoms do persist and still cause impairment, even if a diagnosis is not necessarily there. And so it's really important, as you will hear about later on, I'm sure, that we consider the disorder as persisting across the lifespan. Expounding a little bit more, I do also think it's really interesting in terms of the disorder changing what it looks like across age. And so you can see here on this slide that on the x-axis, we have age increasing from left to right. And what's been found is that the hyperactive impulsive symptoms do seem to decline in sort of relevance, salience, severity as a child gets older. And so typically these symptoms will peak in severity around preschool age, maybe 5, 6, 7, and then decline through adolescence. However, on the other hand, it's also been found that inattentive symptoms, so those ones related to difficulties concentrating and staying organized, tend to persist and stay just as severe across childhood and adolescence. And this is really important because oftentimes the hyperactive impulsive symptoms are the ones that most people sort of link to ADHD. And so when those symptoms start to decline, people think to themselves, oh, like this child's getting better. That's great. However, what can happen is that the inattentive symptoms, which are harder to detect, will persist across development and continue to cause problems. This also leads to a lot of problems in girls who are known to exhibit higher rates of inattentive symptoms than boys. A lot of times you'll have girls with ADHD being somewhat incorrectly diagnosed with like anxiety or something like that because they display inattentive symptoms which aren't as easily like apparently connected to ADHD. So really interesting findings here. Going a little bit deeper into the disorder, I do think this is interestingly, there are no validated attention problems in ADHD. The name attention deficit hyperactivity disorder is kind of incorrect. There are no real documented attention problems in children with ADHD that have been found in the research. What ADHD is, it's a deficit in controlling attention. And so a better way to describe the disorder potentially could be difficulties, children having difficulties paying attention to things when they don't want to pay attention to them. Um, the example that a lot of parents talk to me about is that if you plop a kid with ADHD in front of like a video game, they can play that thing for hours. And so if they want to pay attention to something, they can do that no problem. However, if you put them in a classroom setting where maybe they don't really want to be, it's kind of boring. Typically, developing kids, they have the ability to sort of lock it in, focus, even though they don't necessarily want to. In kids with ADHD, they just do not have the ability to do this as well. And so they struggle with it more. Another thing to mention here is that ADHD is largely unrelated to IQ. And so there has been some lay people talk of it only impacts people from low IQ settings. That's generally not the case. It's been found that ADHD can be diagnosed across the entire IQ spectrum. And then the disorder often is accompanied by poor academic function, speech and language impairments, family and peer problems, and an increased accident proneness across the entire lifespan. It truly is a disorder that is associated with a lot of really poor outcomes. And so it's really important that those with it get the care that they need. And so I mentioned before that ADHD is not really a deficit of attention per se. What it's been better linked to potentially is executive function. And so this is, I know, like a buzzword right now, I think. But executive function can really be viewed as the brain's symphony conductor. And so anytime that we are planning for something in the future or organizing our day or our week, anytime that we are trying to remember things, anytime that we are working towards a long-term goal, that is involving executive function. And kids with ADHD really, really struggle with this. This has been found to be something that impacts children with ADHD pretty significantly. And so to just put things more concretely, I do have a really quick video here showing a way that we measure executive function. And so I'm just going to show it off here.
The marshmallow test is a psychology experiment from the late 1960s, designed by a guy called Walter Mischel. The idea is you give young children a marshmallow and say you can eat it straight away, or if you don't eat it and hold on for 10 minutes, you can get a second marshmallow. It's all about delayed gratification. And Mischel said that those people who are good at the marshmallow test went on to have more successful lives. And we're going to see whether the test works just as well with children of our own generation. We've got Celia, who's 6, and we got B, who is 4. I'm going to give you a marshmallow. If you want, you can eat this straight away, or you can wait for a bit until I come back into the room and you'll get a second marshmallow. Okay? I'll leave it up to you. I'm going to leave the room for a bit. Bye-bye. Okay, girls, how did you do? You haven't eaten yours. And what happened to yours, Bea? Where is it? What, it's there in your tummy? Is it? You couldn't wait for another one. So you, as a reward, get another marshmallow. What do you think of that? Casey?
Okay, so I'm going to move on here. But you can see there that short-term versus long-term reward, that sort of balance that the children in that video were going through. The younger girl seemed to be younger, had more challenge with it, and so ate the marshmallow, whereas the other one was able to hold out and get two. Children with ADHD will really struggle with tasks similar to that one. Anytime there is a short-term versus long-term kind of situation, with ADHD will really be pulled, so to speak, towards that short-term reward. And certainly in the marshmallow test, it's kind of silly, right? It's low stakes, something like that. But we can see how when it's applied to a school situation, a work situation, a life situation, that can have some pretty dramatic impact throughout the lifespan. And so moving forward here, ADHD has been found to impact several areas of the life, and I typically will focus on the school just because that's the world that I come or sort of live in my own work. And so the disorder has been very much linked to different aspects of learning. And so with reading, ADHD, people who have ADHD will really struggle with especially reading comprehension. Anytime there is a task like that where someone has to hold information in their brain, pull it out later, manipulate it, they will really struggle with that. For math, the key issue is going to be multi-step problems. Again, if you ask a child with ADHD to do a multi-step math problem, they're going to really struggle with that. And then writing, any part of writing that is what I like to call grindy, or it's very rote, it's very nitty-gritty. The typical example is going to be editing papers. Children with ADHD will tend to struggle with that as well. And then the big difference, again, to highlight here is that people will struggle with these things at some point of their life. Likely everyone will have some struggle with reading comprehension or editing or something like that. The key difference that makes it a disorder is that people with ADHD will struggle more and then will be unable to kind of make themselves focus and make themselves do it when their brain is pulling them, so to speak, towards other things. And so in sum, putting everything that I talked about up till now together, ADHD has been found to run in families. It has about a 6% prevalence, being more common in boys. It contributes to a whole host of problems throughout the lifespan. And then most importantly, it is treatable. There are some very good evidence-based treatments out there for the disorder that I will get into later on in this presentation. I also highlight here what ADHD is not, just to dispel some common myths. And so ADHD is not something that only affects boys. It's not something that pertains to a lack of effort. And that's something really unfortunate that you hear from a lot of children who have grown up with the disorder, is they will have been told throughout their life, why can't you just try harder? Or why can't you just do better at this stuff? And it actually is that they just cannot do that. They do not have the ability to do that. And so that throughout the lifespan will lead to increased rates of anxiety and depression when they're told that they are failures because they just can't work hard enough to do it. That's a real problem in the field. There is no link between ADHD and vaccines. ADHD is not a function of bad parenting. It is not a disorder exported by the USA. That's a new one to me. I just added to this presentation. And then I said already, ADHD is not linked to low IQ as well. And then just going a little bit deeper on what I just talked about, in terms of being an export of the USA, in current research, you can see the countries on the slide here. These are the ones that are currently contributing to data prevalence rate studies on ADHD. And so I acknowledge there are some gaps, right? You have Southeast Asia, you have the Middle East, you have Africa and South America. There are gaps there. And at the same time, the disorder is not really viewed as something that is exported by the USA. It is kind of a broad problem that impacts children around the world. A lot of times too, I get questions from parents of, are we just over pathologizing normal behaviors? Are we just saying that there is a group of children who they can probably get by, but we're calling them, we're telling them that they have this disorder incorrectly? And that is not really borne out in the research as well. ADHD, as I said, is linked to a whole host of negative outcomes: lower life quality, increased suicidal ideation and attempts, increased depression, increased car accidents, substance use. This disorder is a thing that can really contribute to some negative life outcomes. And so, no, we are not over pathologizing normal behavior. All right, and so that was really defining what the disorder is and what it isn't. Now I'm going to move into kind of the assessment for ADHD, talking about how we screen and diagnose the disorder. And so there are two primary periods where ADHD will typically come into play. The most common one will be in the intermediate years of elementary school. This is typically where the disorder symptoms are first identified by parents and teachers. However, it's also been found that in high school and early college, those are also periods where the disorder can be identified at pretty high rates. The reason for this is that what you will find is that children who have ADHD will receive support from their parents and teachers that in essence covers up for a lot of the deficits that accompany the disorder. We can think of a situation where a child is really struggling with their homework, and so a parent will step in and effectively do the homework for them throughout elementary school. However, once the parents start to fade into the background, the child starts to develop more independence in high school and college. That's another point where you can really see problems emerging as well. And so those are the 2 points where you typically will see the highest rates of ADHD assessment. The common route of ADHD assessment is going to start at the pediatrician, school psychologist, or guidance counselor. Typically, in my experience, it's been a lot of the pediatrician. And it'll be something like this, where you meet with a child or a parent and say something akin to I've noticed these behaviors in myself or my child, and I'd like an evaluation. Do you know of someone who specializes in this? That's the typical routes that we see in terms of ADHD assessment. Following that first step, children will be referred to a specialist who will conduct a comprehensive ADHD assessment. I'll get to that in a second here. And then if the disorder is diagnosed or if a problem is identified, then the child and the family will be referred to treatment. So this is the typical path here. Focusing in on the ADHD diagnostic consultation, this will typically range in length from 1 to 8 hours. At the gold standard, I would estimate between 6 and 7 hours for a comprehensive ADHD assessment battery. And it will involve kind of a combination of all of these things on this slide. And so it will involve a clinical interview with both parents, teachers, child sometimes, anybody else, like a therapist that the child has been working with. And then you'll follow that up with some, what is it called? Objective informant ratings. And so there are some questionnaires out there like the Connors, the Vanderbilts, the ADHD rating scale that are also used to gather information. A broadband assessment for co-occurring problems will also be a really important part of the ADHD assessment to screen for other types of psychopathology, depression, anxiety, oppositional defiant disorder, things like that. And then, although they are not part of the diagnosis, ADHD assessment can often involve a learning, IQ, or executive function assessment, just as supplemental information. These sort of three things here on the bottom right are not included and not considered as part of the ADHD diagnosis. However, they can provide some really important supplemental information on what's going on in the child's life. And so just some quirks in ADHD assessments. And so according to the American Academy of Pediatrics, they recommend assessment for any child or adolescent who presents with academic or behavioral problems and symptoms. And you can see here that the guidelines for when to consider assessment are pretty wide here, which has pros and cons to it, certainly. The primary guidelines are going to be the DSM-5 criteria. And so the key sort of thing to consider here is there is no current objective standardized assessment, so to speak, that you can give to diagnose ADHD. It is primarily given based on whether someone meets the DSM-5 criteria. And that can involve several people in the child's life, parents, guardians, teachers, school personnel, or any mental health providers involved in the child's care. When diagnosing ADHD, step one is going to be to establish the diagnosis by confirming that the individual child meets DSM criteria for ADHD. I went through those earlier, but they're also readily available online all over the place. Step two then is going to be to rule out alternative explanations for the symptoms. This is particularly important these days, given that there's this weird kind of dialectic that's happening where there is more knowledge of ADHD, and so higher awareness and higher rates of diagnosis. And that is great. That's fantastic. At the same time, there is also a potential issue of overdiagnosis in the ADHD community as well. And so it's really important, given that consideration, to rule out alternative explanations for the symptoms. And then step three is going to be to assess for comorbid conditions, which may affect the treatment of ADHD as well as the diagnosis. I'll talk about that in a second here. Some special circumstances to mention. So in particularly young children, so ages 4 to 6, the real problem that can emerge here is that one may have difficulty observing ADHD behaviors in multiple settings. We can think of a child that maybe hasn't started school yet, and so you only have the home. That represents kind of a pretty big challenge for that age. And then in adolescence, there's a lot of considerations here, things like adolescents working with multiple teachers. And so which one are you supposed to get assessment information from? There's oftentimes less parental involvement, limitations of self-reports. There's a lot of people to consider from getting information from. So teachers, coaches, guidance counselors, leaders of community organizations. And then a key consideration is that there needs to be evidence before age 12. And so there'll be a lot of strategies used to kind of get that information, but there's no real clean way of getting it. Report cards, like I said, is a very common method. One additional complication of ADHD diagnoses is that the disorder is highly comorbid with other disorders, with prior research suggesting rates of comorbidity impacting about 75% of those who are diagnosed with occurring in up to 75% with the ADHD diagnosis. Common comorbidities with the disorder have been found to change across childhood and adolescent development. And so in children, the comorbid disorders are going to be more like anxieties. Tic disorders are fairly common. And then the most common, perhaps, is oppositional defiant disorder, where the child's being disruptive. In those cases, it's really important to distinguish the nature of the comorbidity. I'll talk about that in a second, because there's so much overlap in ADHD and ODD during childhood. In adults, the comorbidity patterns shift to look more like depression, anxiety, bipolar disorder, substance use disorders, and then some personality disorders as well. ADHD has been found to be pretty highly comorbid with things like borderline personality disorder and things like that. So a lot of work to be done there too. And so in is sort of class or clarifying comorbidity patterns in those with ADHD, a key step that cannot be overemphasized here, cannot be emphasized enough, is the role of the functional behavioral assessment. Really getting more information beyond just the symptoms of what is going on in the life context that is impacting this child's or that is impacting and influencing this child's problems. This can not only provide like incredibly invaluable information for assessment and treatment purposes, but also help to clarify the nature of what comorbidity looks like, how it develops, and how it best might be treated when someone is diagnosed with ADHD. The functional behavioral assessment in particular can be important in identifying, like I said, the relationship between different risk factors and then different comorbid disorders. These are just 4 models of comorbidity that I pulled from the existing literature base. There are so many ways that one disorder can happen alongside another. And it's really, truly only through the functional behavioral assessment that you can really parse like what's going on here and how can we best treat it. For instance, it's really important to distinguish between secondary problems and comorbidity. And so secondary problems are when something happens as a result of another disorder. And so this would be something like someone with ADHD has difficulties in school, and because of those difficulties, they develop depression. The depression is secondary to ADHD, and so thus by treating the ADHD, you're likely to treat the depression as well. On the other hand, comorbidity is going to be something that is both chronic and pervasive. And so we can think about someone who has ADHD along with an oppositional defiant disorder. Both of those disorders are thought to stem from a shared risk factor of irritability. And so in that case, rather than treating either disorder first, maybe instead we go after and target the irritability and get at both disorders, which are happening sort of alongside one another. And so that all comes from the functional behavioral assessment, and it can drastically change the approach to treatment. So very important to distinguish what's happening in comorbidity. Another consideration in ADHD are cultural differences. And so I'll talk more about this later on as it relates to treatment. But what research has found, what very limited research has found, is that there do seem to be cultural differences in how ADHD is diagnosed. And so in general, it's been found that Asian Americans report the lowest rates of ADHD compared to other racial and ethnic groups in the United States. It's also been found that even when you consider Asian communities, there seem to be differences depending on geographics. And so what the research has suggested, for instance, is that in the US, those in Asian American and Pacific Islander communities report ADHD prevalence rates of about 2%. However, in Asian countries, rates of ADHD are about 6%. And that is all in contrast to non-Hispanic white communities in the US, which have been identified as having rates at 11.3%, so 11%. And so you can see there's some, when we broaden it out to like this global perspective and big scale populations, there are some pretty significant differences that are emerging in the ADHD prevalence rates. And so something is going on here, and it's really important that we take potential cultural differences in how the disorder is perceived or diagnosed. We take those into account because this might be just reality. And so maybe just Asian Americans in the US have lower rates of ADHD. It could be that maybe there's bias in clinicians that's happening. It could be that there is stigma that is preventing access of services. And so really important to parse what is happening that is contributing to the differences in diagnosis here. That's a little bit of what my work focuses on. And then just to complicate things further is other work has suggested that acculturation seems to also play a role in ADHD diagnosis. It's been found that there is a lower prevalence rate of the disorder in Mexican Americans that were born in Mexico versus Mexican Americans that were born in the US. And so that could be acculturation, it could be generational. The important thing is it seems to be a robust finding, and we need to figure out why it's happening. All right, so that was everything that I wanted to talk about in terms of ADHD assessment. Now I'm going to shift into kind of the management of ADHD. And one thing before jumping in that I always highlight here is that every child and counselor, and you could probably put everything here, and parent and teacher is unique. And so I have worked with several cases where in one case, an intervention works great, fantastic. Everyone is on board, the intervention takes, and things work out fantastic. And then you've picked that up and used that in a different situation, and it doesn't work at all. And so it's really important to account for heterogeneity in the clients and the stakeholders that are involved in any type of treatment and mental health care while working in this field. But, or that being said, there are some large generalizations that we can make based on prior research. There are really three pillars that have been found that promote the best outcomes in ADHD treatment. And so the first one is that it takes a team. Certainly, it is a disadvantage if it's just the child and the single mental health care provider that is oriented towards treatment. That is a really tough situation to be in. It's much better if there are several people involved. Another thing that we have found kind of across the board is that criticizing bad behavior makes things worse. And so the real emphasis that the field has turned to is to adopt this proactive approach. Rather than disciplining as the primary go-to, which a lot of parents turn to quite understandably in their parenting approaches, instead, it's much better to set up a child for success. Praise the behaviors that we want to see, encourage those at the same time, and set up situations to promote success. I'll talk more about that in a bit here. And then one thing I like to focus on here is timeout. Timeout is very commonly used, particularly in ADHD-oriented populations. And I am not here to bash on it. Timeout is an incredibly useful parenting and discipline tool when used in the correct way. The issue that often comes up is it is not used in the correct way. And the common scenario that I have found in my own line of work is that a child with ADHD is in school or at home, doesn't want to do their work. And so the parent or teacher gets upset and then puts them in timeout. The issue, as I'm sure many in here are thinking of already, that happens in that situation is we have just effectively given the child what they wanted to. And so the child didn't want to do work, and by punishing them, we have set up a situation where they don't have to do work. And so what that does is the child learns, oh, I just have to continue acting in this way, and I won't have to do work anymore. And so all this is to say is that we really want to be strategic about how we use timeouts. If the goal is to avoid work, it's much better to rely on a different strategy. On the other hand, if the goal is to get peer or parent-teacher attention, in that case, timeout will be useful. Again, the key question here is, why are we using timeout? What is happening here? But moving back to intervention, there are also, in addition to those pillars, some key themes that have emerged in the literature. And so the first one is going to be more movement. The second one is more feedback. The third is increasing praise. The fourth is breaking tasks and instructions down. And then the fifth is externalizing reminders. I will go much more into detail on each of these themes, but you will notice that they are inherent across all of the management techniques that I'm about to speak of moving forward here. And when we break down interventions for ADHD, the best way that I have found to do it, at least in these types of presentations, is through these zones of intervention. And so you can see, I know it's small text, apologies for that, but at the middle, we have the child, and then at each level, we branch out. And so at the second level, we have the task, the third is the classroom, the fourth is the teacher, and then the fifth is the parents and caregivers. And I'll be going through each one of these zones specifically as we build kind of a toolbox here together on the current evidence-based interventions for ADHD. And so let's go ahead and start at the child zone here. And within the child zone, largely you can group interventions into three specific areas. As listed here on the slide, I'm going to go through each one now. And so the first one is medication. So I can only speak to this as a clinical psychologist. I'm not a psychiatrist. At the same time, what the research has suggested is that medication helps in about 70% of cases of ADHD. There is a huge stigma that is still in the field or in parent circles towards medications. That's what we have found here in our own research. And the medication work has come a very long way from what it was in the past. And so I'm sure many in here are familiar with it, but many ADHD medications are very flexible in how they are administered. And so most can be stopped and started. It's very common for children with ADHD to take their medications in the morning. And then by the time school is done, the medication is completely out of their system. I've worked with cases where kids will take medication on school days and then not take them on the weekend. The administration is very, very flexible of ADHD medications. The side effects are also very mild or fairly mild. The most common one that is seen today is going to be appetite suppression. That being said, what I always encourage parents to do is when their child is prescribed medication by their pediatrician or a psychiatrist, is to make a follow-up appointment. There's a bunch of different types of ADHD medications. And oftentimes, the endeavor of it is going to be figuring out which one works best for this child. And so follow-up visits are very, very important. If one medication doesn't work, it's highly likely that another one will. So it's just about finding them. There are also no evidence of long-term negative effects of medication. There's no real evidence of addiction difficulties linked to ADHD medication. And then I always state at this point, because I think it's interesting, I know right now there is a growing problem of particularly college students using ADHD or non-prescribed ADHD medications to help them with tests or things like that. One thing for all of your pockets as you go into your own practice is there is no evidence of that working in terms of like improving grades or GPA or outcomes. There is no evidence that when taken in a non-prescribed manner, that ADHD medications help somebody with ADHD gets better grades. That just hasn't been found. I think that's interesting. All right, moving to the fuel intervention. It has been found certainly that all children benefit from healthy diets. What's been found is that children with ADHD benefit more. And so What I usually will recommend is what I call easy to eat food. And so that will be something like granola bars, apples, some sort of snacks, things like that. The not easy to eat food will be something like soup, where it's just a little bit more effortful to eat. In general, we try to discourage those. And then the time to really zone in on these easy to eat foods is going to be in the early afternoon, around like 2 p.m. It's been found that all people go through kind of this afternoon siesta, so to speak. And so with children who have ADHD, I typically will recommend like a juice box or a granola bar just to make sure to keep the energy level high so that they can regulate themselves. Oh, there. And then the last zone, the last intervention within the child zone is going to be movement. And so this is true for any child, but with kids who have ADHD, anytime that there is a way that we can make them use energy, we are going to do that. And so I have worked with parents and recommended that they drop off their child a few blocks from school. It's a win-win. So the child gets to burn off some energy, and then the parent doesn't have to sit in traffic for minutes. At recess and lunch, encouraging children, particularly those with ADHD, to get up, move around, play, do something. The worst thing that what someone can do in a school setting is when a child with ADHD is misbehaving to punish them by removing some sort of recess or lunch. You've effectively just bottled up all of that energy for later on. In certain situations, we have been able to work with children to move at their desk, either through like Tic Tacs or fidget toys. It has been found that when children are allowed to doodle, so like sort of draw things on their paper, it does facilitate learning so long as the doodling is on the topic at hand. And so you want to make sure that they are doodling about whatever the class topic is. Any movement during class, like I said, this can look like a lot of things from passing out papers, changing things on the calendar or like the class schedule, delivering things to the principal's office or the offices, things like that. That's been super helpful. And then perhaps most importantly is this idea of a hallway pass where we work with all stakeholders to develop a certain number of times that when a child just can't sit still anymore, they hit that peak where like, I got to do something. They're allowed to get up, leave the classroom without necessarily asking the teacher. So it can be a very subtle thing. And then they're allowed to go and use the restroom or something like that. The guidelines typically will specify very strictly beforehand. And so something like, hey, Timmy, whenever you need, just give the teacher a wave, leave the classroom. You're allowed to walk around the hallway 2 times and then come back to the classroom. Something like that can be super helpful for helping children be able to regulate themselves in the classroom setting. And so, as I said before, we're kind of building this toolbox that we use of gold standard interventions for ADHD. And we've talked about here easy eating, more movement, activity role in class, so having some sort of activity in the classroom, and then having activity breaks as well, something like a hallway pass. All right, let's go ahead and broaden out now to the task zone. And there are really 3 primary interventions in this task zone here. This is going to be the choice of task, breaking tasks down, and then what we call active learning. For choice of tasks, it's been found that when children are given the option to work on a task of their choosing, it increases motivation significantly. And so this is particularly true in children with ADHD. I do highlight here always that the choices that are given to a child in these kind of scenarios aren't going to be something akin to like, you can do something or you can do nothing. That's generally not what we do. It's going to be something along the lines of you can work on your math homework or you can start with your reading homework first. Although it's both work, giving a child choice drastically increases motivation. And as we know, as we talked about earlier, the primary deficit in ADHD is not being able to pay attention to things that a child doesn't want to pay attention to. And so building motivation will take all the help we can get in that area. Additionally, it's really important to make sure that we build interest in the things that a child is working on. I worked with a child who absolutely hated reading, hated everything about it, and never wanted to do it. However, this all changed when y'all might have heard of it, but there's that book, Diary of a Wimpy Kid, that came out during our time together. It was very oriented and accessible towards children. There was fewer words on a page. It was funny. It was relatable. And then all of a sudden, this kid couldn't stop reading. And so really, it's about orienting towards what interests the child as much as reasonably possible. The second intervention here is breaking tasks down. This is really what it looks like or what it sounds like, and certainly involves a ton of collaboration to see what is reasonable from a teacher's perspective, what is possible, things like that. But that being said, with reading, anytime that we can just put fewer words in front of a child with ADHD, that is an absolute win. It's been found that that builds motivation. We'll use something like a Kindle when sort of the means are available, because you can kind of blow up the text and put fewer words on a page, so to speak, less material on a page. With writing, these handouts, these are readily available online, like things like this. You can just Google them. But anytime there's a way that you can break down the writing into smaller pieces, that has been found to really help children with ADHD kind of organize their thoughts and put it all down on paper. And then for math, even something as simple as just putting fewer problems on a page. And so we look at the left, that is just by nature more accessible than a very similar problem sheet on the right here. And we found that when children with ADHD are presented with the worksheet on the left, so the worksheet with fewer problems, motivation just increases. It is less overwhelming and more accessible. The common sort of question I get here is, why are we making things, are we making things too easy? I get that question a lot from parents. I don't want to, you get a lot of, I don't want to handicap my kid. I don't want to, set expectations too low. We work with a lot of that in our work here. My response always is, well, right now, your child is not doing anything. And so right now, the bar is essentially 0. And so let's start with kind of meeting your child where they're at. And maybe it's a little bit easy, sure. But if the child starts to build motivation and be less overwhelmed by these things, in the long run, then they can start to catch up. And so that's typically what I will say to parents who push back against making things easier is, right now, some is better than none. And it's oftentimes that some can continue to grow over time. And then lastly, within the task zone is going to be active learning. Anytime that we can move a child with ADHD out of a space of just sort of sitting there and reading something silently, we are going to push towards that. And so if there is opportunity to read aloud, if there's opportunity to highlight, work on hands-on projects, all of those are highly encouraged as great interventions for ADHD. Audio recordings are also something that can be helpful, given that what the research has generally shown is that it will be kind of like a static on a TV. That's the ADHD experience, so to speak, where the attention will kind of zone in on what teacher is saying. And then the static will come in, they'll kind of be distracted by something, and then they'll come back and attention will focus again. To fill those gaps, any type of audio recording is super helpful. There is a new technology out there right now that is expensive, and so it's not very accessible, but the potential is really compelling. There are smart note pens, I guess, so to speak, that you can buy on Amazon, where essentially you take a notes on like an iPad app, and then the pen records what was being said at the time. And when you push on the area where the note was being taken later on, it will play back the audio. And so that's like a multi-source kind of intervention to facilitate learning. And so that can be really helpful. It is, I think, still pretty pricey. And so I don't know how real world application we are with that right now, but certainly that can be something to keep tabs on for the future. I had a friend who had ADHD, who was able to get through graduate school solely because of things like that. And so definitely helpful. All right, so within this practical list we're building, these are the things we had talked about previously. And these are the ones that these are the interventions that fell into the task zone. So you break tasks down, give a choice, and an audio recording. Okay, so let's go ahead and move into the classroom zone here. And then there are three primary interventions that have been supported by the literature in this area. The first one is to reduce distractions, second, externalize info, and then the second is timeout. Or I already spoke on timeout, so I won't be covering that here. But with regards to the first two, anytime that there is a chance to reduce distractions, certainly that's helpful for all children. For children with ADHD, it is incredibly helpful. And this can look like a lot of things, but just focusing on the classroom setting again, because this is where children spend most of their time during that age, seating type is a huge kind of area for intervention here. I know some schools out there will do the desk configuration where children are sitting like 4 desks pushed together. That's generally not a fantastic situation for a child with ADHD to promote learning. When the means are possible, we really want to promote sort of individual desk seating. Another thing to consider is it's very common, or it's not very common, but it happens, where when a child is misbehaving, a child will or a teacher will move that child to like the back of the classroom. In general, that again does not really promote learning. And so whenever possible, we really encourage that for children with ADHD or really any type of behavioral issue, place them as close to the teacher as possible, place them away from their friends, any doors or windows in the classroom, so that the environment really facilitates learning. And then the second intervention within the classroom zone is to externalize info and to set routines. And so, like I said, one of the primary deficits of ADHD is the ability to hold information in the brain or in memory, so to speak. And so anytime that there's a way that we can take that out of a child or a teen's brain and put it on paper, that is super helpful for kind of functioning in these types of settings. And so anytime that there's an opportunity to write something down in terms of due dates, particularly if we combine it with like the breaking down of tasks, that's a huge opportunity for a win. Oftentimes we will encourage teachers to create like a daily schedule that is on a poster and post it in the class. And so that children with ADHD can refer back to it over and over, and kind of, again, it orients them to what the day looks like and removes that information from, in the brain where they have trouble holding it, so to speak. All right, and then moving now to the teacher level. This one is pretty straightforward. It really focuses on 2 areas. That's what we found, is instructions and praise. And so I will talk more about praise with regard to parents in a few minutes here. But praise is really the gold standard intervention for ADHD and any type of behavioral issues as well. And so it's been found that praise is the most effective way to increase desired behavior because it tells a child what to do. If we tell a child, don't do this, don't do this, don't do this, That's great for telling them what not to do. But an issue that often happens is then a child doesn't know what to do. And so really we orient around praising anything towards those positive behaviors. And then the other teacher zone intervention is providing instructions one at a time. I once worked with a child who said that they would go to school and then the teacher would say something like, okay, class, go ahead and take out your textbooks, turn to chapter 5, read through the chapter, and then answer the questions at the end of it. Something like that. Pretty straightforward instructions, so to speak, for a classroom setting. The issue that would happen in this case, this child was diagnosed with ADHD, is by the time the teacher finished the instructions, the child was still trying to remember where they had put their backpack. And so really providing concrete steps one at a time, and then praising each time within reason, right? Within reason, praising as children accomplish those steps, huge intervention win there. And so in building a practical list, again, returning here, I combine kind of the task or the classroom and the teacher zones to sitting near the teacher and using single desks, posting daily schedules, step-by-step instructions, and then targeted praise. And so that brings us to the parents and caregivers zone here. And I kind of did this a little trickily, so to speak, in that particularly for young children, I would say this is mostly where we live. We mostly, when working particularly with young children, think like below the age of 12, we'll focus mostly on the parents and caregivers. Oftentimes, teachers are kind of not really part of the intervention picture because of accessibility issues. And then the child, what we found is that while we can use the interventions that I just talked about, when ADHD is part of the picture, you meet with a child for 1 hour a week, and then the child leaves and forgets everything that you talked about. And so really orienting around the parents and caregivers, we have found to be the most evidence-based intervention, or have the strongest evidence base in terms of ADHD-oriented interventions. And so we're going to go through these. There are a lot of them here. And so I should have said too, is that after the fact, I will be sending out the slides as a PDF. And I'm happy to provide more consultation or detail if there are any questions or anyone wants more information on any of the skills that I have talked about here. But we're going to go through each of these here. And so oftentimes the first thing that we do with parents is going to be, or caregivers, is focus on psychoeducation. It is very common, particularly here in Hawaii, that mental health literacy is not super high. And so really taking ADHD, moving it to like an accessible language, and then a huge part of it is going to be removing blame for the problems that are resulting from the disorder. And so a lot of times there's a lot of stigma that is residing in either the caregivers towards the child, towards themselves, anything like that. Really the first bit of time that we spend with the parents, we focus on addressing that stigma through psychoeducation. And so we're providing information on the nature of ADHD, as well as getting context on what's been happening that's contributed to any problems in the home or school. This image that I'm showing on the screen here is one of the primary ways that we do that. And so you can see on this screen, or on this worksheet, I suppose, there are 4 different factors that are thought to contribute to problems. Say it like that. There's the child, there's the parent, there's the life events, and then there's the way consequences have been used in the past. All of these things have been found to contribute to problematic behavior and interpersonal dysfunction in parent-child interactions. And one key thing that we try to emphasize while filling this worksheet out is the removal of blame. We're not really here to blame the parent or blame the child. We're just trying to figure out, like, there is a problem. You all agree that there's a problem going on. What are the things that are contributing to it so that we can work together to solve it? It really moves it through sort of a motivational, interviewing, collaborative space to a point where we're all working together to understand what's going on. I talked about it earlier, but with parents, targeted praise is incredibly important. And so the recommendations are often to provide immediate and consistent praise. I put consistent praise twice, sorry. And then importantly, praise behavior that happens by itself as well. And so oftentimes with parents, we'll set a goal, right? Some sort of behavioral goal. We want Timmy to wash the dishes, something like that. And then we'll encourage the parent anytime that Timmy follows their instructions and washes the dishes, even a little bit, to praise the heck out of that behavior. And then most importantly, perhaps, once Timmy starts doing that behavior without prompting, then praise that as well. Immediate and consistent praise is one of the most important interventions when dealing with ADHD or disruptive behavior related problems. I will also emphasize here that this is found to be more powerful than external praise. So I'll talk about token economies later on of giving children, like little trinkets when they do good behavior. The research has suggested that praise is longer lasting and more powerful than those external rewards. And so we really start here. The next intervention is called one-on-one time. And so this is non-directive and non-judgmental playing. The scenario is essentially that the parent is going to sit with their child and let the child lead the play session. And importantly, the parent in these scenarios, we try to make sure they are not asking questions, giving instructions, or criticizing any type of behavior that the child is doing. Certainly within reason. The child is putting anyone in danger. Yeah, like let's lock that down, or let's shut that down. And at the same time, the goal of this is to allow the child to develop a sense of positive interaction with the parent, and then for the parent to also have some positive interaction with child too, where there's flexibility, the child is leading, and really being given time to be an explorer and like a participant in this play session. The reason for one-on-one time is what we hear from parents a lot is that all interactions between them and their children are criticism-based. Don't do this, punish you for this. And what that leads to is essentially no good feelings and a poor relationship between parents and child. And so the criticisms become more harsh and you sort of go down that hole. The one-on-one time is designed to build kind of a piggy bank of positive experiences that later on, when things aren't so great, both parent and child can kind of remember and use to get them through those tougher moments. And so this has also been found to be a very useful intervention for improving the relationship quality between parents and their children. Another intervention that I'll talk about we often do with parents is called active ignoring. This one is kind of what it sounds like. The ignoring part is going to be ignoring problematic behaviors used to get attention. And so anytime that the child does something, oftentimes this will be like interrupting conversations in the scope of ADHD. It will be like interrupting conversations or something like that. The parent just ignores the child. No anger, no punishment, so to speak. You're just kind of ignoring what they're doing. However, the active part is the moment that the child exhibits behavior that we want to see, then we catch them being good. Praise the heck out of it. And so we get the most bang for our buck here. You're ignoring the problematic behaviors and decreasing their likelihood and frequency. And at the same time, you're catching them be good, increasing the likelihood of good behaviors here. I've worked with parents who really struggled with this one. And so this one is definitely a challenge, but it really pays some dividends when you have parents that are willing to work with you and stick with it. All right, two more interventions here. The first one is token reinforcement. And so we often use this in classroom settings. It is less powerful long-term than praise, but it can definitely be an important tool. Essentially this, and I'm sure a lot of you here are familiar with, you establish some sort of specific goal, break it down into smaller units, smaller steps, and then provide some sort of token whenever a step is taken. I've worked with kids before, and it's always stickers. We always use stickers. Kids go nuts for stickers. It becomes like Hunger Games when we are using stickers. I don't know what it is, but it works. After they get enough stickers, they can then turn these stickers in for privileges, whether that's more recess time, a small toy, school supplies, things like that. There are some considerations here that sort of lessen my enthusiasm for token reinforcement. It's been found that external reinforcers just get less reinforcing over time. We as adults can certainly identify with this, right? When we buy something new, it's new and shiny and it's super cool for a while, and then it just becomes less interesting. The exact same thing happens with token reinforcement. There's certainly practicality and the reactions of other students. And so we've tried this in classrooms. And if children see one student getting stuff, then certainly all students are going to suddenly want stuff. And so it's certainly a consideration in terms of the practicality of the token reinforcement economy. And then the last thing to mention here is just social skills training. And so this one is honestly exactly what it sounds like as well, where you identify what the social problem is. It's very common for children with ADHD to have social difficulties. And then you discuss alternative ways to respond and then role play it. I once worked with a young adult with ADHD who would go to her boss to ask for something. Her boss would talk about something. She would talk about something. They go back and forth. And then they would be talking about something completely different than what she had initially gone into the meeting for. And so treatment really focused on role playing. Okay, what's it going to look like when your boss tries to go on tangents with you? What are you going to say? Let's practice. She was able to do it. And so we celebrated that success too. And so really that's just the social skills training component, very widely used in ADHD intervention as well. All right, so now we move back to the practical list here. And we've added a whole bunch, but those are typically the parent-oriented interventions that we spend the bulk of time, at least in our practice, using in the cases of ADHD and disruptive behaviors. And so with that, I return to the 3 pillars of ADHD treatment. It takes a team. Criticizing the bad behavior makes the symptoms worse. And so we really want to adopt a proactive approach, setting the environment up for success and then praising when it happens or when the target behaviors are achieved. And then within that, we encourage more movement, more feedback, an increasing of praise, breaking tasks and instructions down, and then externalizing the reminders. That really is kind of evidence-based intervention for ADHD. And I'm happy to talk more if there are questions down the line after this presentation. I also do make it a point here to make sure to emphasize a focusing on strengths. Children with ADHD, youth with ADHD have a ton of strengths. They're incredibly creative. That energy that they have can be infectious. They're often hilarious. And so really figuring out how to focus and use these strengths can be a huge part of therapy as well. And so within that too, it's also not something that necessarily has to hold somebody back. I'm sure everyone in here knows of Simone Biles, world-class Olympic gold medal. I don't know, has won the Olympic gold medal like a billion times now. She has a diagnosis of ADHD and yet has achieved so much. And so all this says is that ADHD is absolutely not the end of the world. It's incredibly treatable, and people can achieve incredible things in the context of this condition. Okay. All right, so I have a few minutes left here, and I want to spend them talking about two novel research areas that I find particularly compelling. These are very new research areas, and so I'm curious to hear all of your thoughts on them too. The first one regards cultural differences in ADHD intervention. What's been found in the research is that current gold standard therapies, including the ones that I spoke of earlier, can conflict, particularly with Asian heritage parenting values. Just huge generalization, but in general, Asian parenting values tend to focus more on parental control, the family hierarchy, and then children complying, right? Children compliance. And then when compared to sort of more Eurocentric parenting styles, Asian parenting styles tend to also focus more on criticism as opposed to reward and praise. And certainly this comes into conflict with a lot of the interventions that I talked about, right? A lot of the ADHD interventions are designed around being more flexible with children who have the disorder or praising them, right? And so that is a huge issue that's been identified in the ADHD intervention research base today. And as a result, it's been found also that Asians tend to endorse fewer benefits and more barriers to ADHD treatment compared to their white peers. That is something that has been found in the little bit of research that's been done in this area. And this was taken a step forward by one of my colleagues, Sarah Chung. She works at University of California, San Francisco. I don't know if she's in here. That'd be super cool. But she conducted research in the past year in Asian American families and found that Asian American parents actually report significantly lower treatment expectations for ADHD behavioral treatment. At the start of treatment, they just endorse this idea that treatment is not going to be that effective, or at least to a lower degree than their white peers. What this leads to then is lower engagement in treatment. And this is a huge problem that has been found pretty robustly across the Asian American community, where there is just statistically significant lower levels of engagement in behavioral treatment for ADHD. And then what this leads to after that is then worse outcomes and the fewest reported benefits. And so a real issue that's happening here with regards to kind of the cultural components of ADHD behavioral intervention. And what Chung and colleagues said is that this really highlights a need for cultural adaptation in behavioral therapies of ADHD. And where they went to, their recommendations was really assessing parental expectations before treatment, really focusing on the psychoeducation piece and meeting parents, particularly those from racial and ethnic minorities, and then Asian Americans in particular, those communities, providing psychoeducation on the nature of ADHD and interventions. And then the last recommendation was starting with more culturally congruent skills. It's been found a little bit, there's still research that needs to be done here, but it's been found that focusing more on skills that improve classroom behavior first tend to be more accepted culturally by Asian American parents. And then once you get those wins in the classroom, then you can sort of have the buy-in to do the more parenting style interventions. There's also been proposal of delaying or modifying what are called culturally incongruent skills. And so this would be something like maybe modifying like the praise element, figuring out if there's a way, mom, like what kind of things do you feel okay praising? While still maybe you can criticize some things, we can be flexible on that. Really sort of figuring out that balance and meeting parents where they're at. But this is research, hot off the press, was just published. Shout out to Sarah. She's an incredible researcher. She and I are collaborating on some projects focused on Asian American parenting of ADHD. And so look out for that. Hope to come back. If I ever come back, I can provide you all with an update. The other area that I focus, this is the last thing here, is ADHD and social media. Recently, over the past few years, there is a growing presence of ADHD on social media, particularly on TikTok. A lot of times you'll find things like personal stories and experiences, along with some education stuff too. It is in there. Hashtag ADHD is currently the 7th most popular health-related hashtag on TikTok. For those who are not into the social media, ADHD as a topic is incredibly popular on TikTok. That's essentially what that means. And certainly there are pros and cons to the growing awareness of ADHD on social media, right? We have things like increased awareness and acceptance, finding new information, particularly in communities where previously they may not have had that information at all. It has been found that the increased awareness has encouraged people to come forward for an assessment and reduced stigma. And then at the potentially the most ideal level, what social media is really about is finding online communities, right? And we think of these particular, like maybe there are some regions of the world where there would be no community for ADHD or for people with ADHD or for those who think they might suffer from it. Social media provides a huge avenue, really promising avenue for people to be able to find those communities. And so there are certainly pros. And I would be remiss if I didn't also identify the cons of ADHD on social media as well. And so potentially the biggest one that's been proposed is inaccurate self-diagnosis. I had no idea about this, but the new term has been proposed as cyberchondria, akin to hypochondria, where because of something said online and social media, people are pathologizing their own behavior, potentially incorrectly. This was particularly relevant for tic disorders over the past few years in young adult women, where they were not like, I don't want to say incorrectly, but while not necessarily meeting criteria for tic disorders, they were thinking that they had it, say it that way. There is also a reinforcing of negative stereotypes and not always presenting facts. It's important to note that at least in social media's current form, the goal remains entertainment and exposure. Psychoeducation, certainly part of the equation. I do not doubt that. And we cannot get away from the current structure that social media's goal is exposure. And then just general lack of qualification of content creators. And in relation to that, there was a study done in 2022 where that assessed the top 100 most popular videos about ADHD on TikTok. For reference, this is incorrect, but those 100 videos were viewed 283 million times. And so that's the number of exposure that we're working with here. The videos were rated as misleading, useful, or a personal experience. Misleading would be is if there was unsubstantiated or incorrect claims made as part of the video. A common example right now is there's a growing thing on TikTok that where ADHD has been linked to object permanence. That is not a thing, at least in the research base. And so that would be misleading. Useful would be a video describing ADHD signs and symptoms. And then personal experience would be something where a person with ADHD is correctly describing their own experience with the disorder. And so they had 2 reviewers, and what the reviewers found was that more than half, I guess, of the videos, the information could be qualified and classified as misleading. 27% personal experience, and only 21% labeled as useful. And so kind of concerning statistics, definitely things to keep in mind. With sort of the broad conclusions within this being that social media, it's been generally found that social media does not cause ADHD. It's generally been consistently found in the literature base. At the same time, though, what's also been found is that social media use can exacerbate already present symptoms of ADHD and other mental health conditions. And so it's really important that we incorporate sort of social media consideration into ADHD intervention and treatment. that is everything that I wanted to cover today. I do like to leave everyone off with some other resources. The primary one is going to be CHAD. So that's an organization based in Philadelphia that provides really good resources and accessible resources for parents with who have children with ADHD. There's the ADD magazine and podcast, as well as the primary guide, the book, if you will, on ADHD, written by Dr. Russ Barkley, taking charge of ADHD. And then lastly, I know I just gave a thing on social media, but there is this channel on YouTube called How to ADHD that provides some really good advice on managing life with the disorder. It's done by a young woman who has ADHD and presents information in an incredibly accessible manner. And so I have used this with teens who have ADHD, and they found it to be super helpful. Here are my references, and I want to thank everyone for taking time out of their Sunday to join me here. And I'm open to any questions that anyone has. Thanks so much for being with me here.